Go meet with the staff. Go find out the history. Go get that mission and vision and culture of where you're going to be. Why did they set up the program? But that's not, you don't just take what they tell you. You have to do a literature research. Okay, so I did. The research says you can prevent those readmissions for the patients with COPD, because I told you it was preventable and it was treatable. Medicare says within 30 days, almost 18% of Medicare patient beneficiaries are re-hospitalized. Whoa. So we have room for improvement. Medicare payments, the Commission estimates that 76% of these readmissions are preventable. So of this, we can get over 75% out of there. So there is a goal and room for improvement. So I said, okay, we can look at what the PCRC is doing and what can we do. So in the research that I looked, Medicare is always looking at reducing these numbers, and they're looking at how they can do it. So in Medicare, they are looking at innovative ways that they can improve. So in Medicare, they have this program where they will set up grant money to hospitals to do pilot programs to improve care. They say if you're showing something that improves patient safety, improves readmissions, or something, that will, because the biggest dissatisfier in hospitals are readmissions and people being discharged. Care coordination among professionals at various points across the service lines with intent of lowering costs and better outcomes is the goal, believe it or not, in Medicare. We all look at insurance companies and say they don't care, they're just out there taking the money. But their initiatives are actually to drive down costs. 3 things that you should look for when you are looking for better initiatives are planning of the care, timely communication, and the carrying out of procedures at the point of care to positively impact the care of the patients. So is that built into our PCRC? So with that in my mind, as I was working through that, I said, let me see, those would be my goals as I watched to see what was going on. Because if that is occurring, these things, according to CMS and Medicare, will lead to better and higher patient satisfaction, positive patient outcomes, and fewer readmissions. So now we're at the PCRC, and I think we all recognize that because that is where we are today. In fact, we have the luxury of being in their conference room. This is the partnership. This is our building. This is the relationship between Mon Valley Hospital and with the PRHI. And I believe you can all read this. This is the responsibilities of this department to coordinate the care. They work with respiratory therapy. They have pharmacy consultation. They have the smoking cessation, which you heard is their biggest emphasis because 40% of the time, this is what they need to do, diabetes and nutrition. Okay, this is their role, is how they fit into the hospital. There's numerous ways that they can be contacted. They can get consults from nursing, consults from doctors, from the ER. They're all followed by a care nurse manager. Results are shared with physicians. They send progress reports off to the physicians after every visit by the staff. Education is provided by the patient to the patients, well documented, which I saw when I did my review. They get medications and self-management skills. They do home action skills. There's documentations by the PharmD. Any physician may refer, and those referrals are free. And right now, they started out only as COPD. And as a brand new baby, this department then picked up CHF and CAD. So not only were they just beginning to walk, this group picked up 2 other entities. And home visits are also on their slate. Okay, so now let's meet the team. Okay, in our audience, we are very fortunate to have Sue Campus, who is the lead care manager, Deborah Holman, care manager, Sharon Nash, care manager, Care Anderson, our PharmD, Donna Roma-Savage, who is the senior VP of the program, Kristen Bela, who is the director of social work, Alberta Guy, Bev Tokar, and we have other members of the audience. But this was the project team who was the support as I was going through my practicum. Some are here and some are not, again, because of the Joint Commission being here for the total hip and knee. One point I do want to talk about is the cost analysis. When you do any type of practicum, they always say, what's the cost involved when you're doing something? Well, this project was set up with the Pittsburgh Regional Health Initiative. And so I just want to allude to this because this is a unique situation for the PCRC. They received a $10.4 million grant from, as I mentioned, the CMS before, how they're looking for innovative ways for patient safety. And this is one of the ways that they're doing it, to build a pilot program where we can do what? Increase patient satisfaction, have what? Good outcomes, and make sure what? We reduce readmissions. And Lou, our president and CEO, Lou Panza, spoke about that. And we are very fortunate because there was only a few grants across the nation, and we were one to receive it. So we are working in that mode. Now, this is a grant-funded program, and all the monies are directed right to the hospital. However, this department is set up as an independent department of the hospital, and all the funding goes through the hospital to this department. That's the extent of I know about the finances, and that was the extent of my practicum. Okay? Now, as you're setting up any practicum, you have to do an evaluation as you develop your objectives, and it's called a SWOT analysis. You look at the strengths of the program, you look at the weakness, the opportunities, and the threats. I want to go in reverse. I want to look at the threats, the weaknesses, because I really want to talk about the opportunities and strengths because I think there were so many. The threats to the program is grant funded and it's 3 years. But I think this program will really continue. The depth of the staffing for weekends. When they started, they have a great staff, but this staff has a lot of vacations. So they're going to have to deal with 4 people, a lot of vacations, and they're going to be doing weekend coverage. So they're going to have times when they're going to look and say who's here and who's not. So they're going to probably have some issues with staffing as that goes on. The weakness is it's a new program, and they are just learning. Everything here they had to build from the ground up. I remember one of the first things they told me, because I was here like even before the department started, and they said we have to buy our own coffee pot. You know, we have to find drawers for our desks. So it's just learning everything new. The other thing is they added CHF and CAD right off the bat when they started up with the only goal of COPD. And it's the learning curve, just the documentation. They don't only have to document for the hospital system with Meditech, they also have to document for the outpatient visits and then have to try to get those to merge and make sure they're doing everything right. So there's a lot of compliance issues right there. So that is a weakness I see within the system. But for the opportunities, I think there is a huge opportunity for the hospital to make this wide for the whole institution. And I think as you're going to see, as you follow the healthcare movement, that this transition care is just going to be huge. And Mon Valley is on the leading edge. So I think they're really great there. And it's going to be very good with the CMS and the Joint Commission. Their strength, the knowledge and enthusiasm. And I'm not just saying it because I was with them, but when you see them when they're working and how they just readily go out and talk to the staff and they work with their patients and make phone calls and how they accepted a student, like I said, before they even started. Not a problem. And the cooperation they have with the staff, with the medical staff, nursing staff, and the other disciplines, phenomenal. But I think what is unique to this program is that interdisciplinary mix that they have that brings that to the table. In the mix, they have nurses and pharmacists who have the varied background. You have the expertise of the clinical nursing, the utilization review. You can't see this word, but it's education, and pharmacy. Everything that really develops and helps those patients. I think that's what makes this such a great program. The other thing you have to do is once you get all that knowledge, you say, now I'm going to develop my student objectives. And this is how you do it based on this taxonomy. Okay, so these were the objectives that I developed. Now this is the embellished version of what the objectives were, but the 3 basic objectives were identify COPD patients on admission and develop specific interventions, reduce 30-day admissions for patients with COPD, improve information flow between patients and other disciplines. Now the first one, reduce 30-day admissions for COPD patients. We really decided we could not do that. You cannot take a snapshot of one day and say, wow, we've reduced 30-day admissions. Or we would be miracle workers. They would take Mon Valley and just say, yeah, you're doing good. So we could not do that. That would not be realistic. But we could work with the other ones, which was identify COPDs upon admissions and look at specific interventions. We could look at improved information flow, house of documentation, and working with interdisciplines. And then the other one we added was developing that PI plan so we would have the infrastructure and the indicators so Susan and her staff could say, am I at threshold? So those were the objectives which are under evaluate and analysis and comprehension. Look at the workflow of the nurse care manager's assignment for appropriate patient identification, because right now they're looking at 100% of any patient who comes in that has COPD attached to the diagnosis. Anybody. It's not like primary COPD, secondary. If somebody comes in for anything, it's there. So it's to determine what data is needed to move the program forward. Analysis, compare and contrast the demographics, looking at readmission, diagnosis, physicians, and preventable, and comprehension. Let's summarize what we found. So that's what I was going to do with all the data that I was required to look at. So really, this is what I was doing when I'd come up and say, Susan, and knocked on that door like a little student and say, I want to look at the charts. So Susan said, here's a list. And the list had 67 charts. But on that list, there was one error. So it was really 66, okay? So there were 66 EMR records that were analyzed retrospectively because I could not do it when the staff was busy with those charts. So of those charts, we had 43 females and 23 males. These were all patients who were hospitalized in Mon Valley during the month of July. The average age was 69 for both males or females. In this review,